afternoon, everyone. I'm Catherine Ward, and I'm the co-director of the Alan J. Flisher Center for Public Mental Health. And as you know, the center is a collaboration between two universities. So it's us here at UCT in psychiatry and Stellenbosch, the psychology department. So on behalf of Ashraf Kaji and I, we're very excited for you to join us today for our memorial lecture for Alan. And as you know, Alan really played an amazing role in the way that public mental health has developed, both in South Africa, and globally. So it really is a privilege and an honor to be here today with another prime example of someone who's really done a lot of work in public mental health. So Cathy Ward is a professor of psychology and is the director of the Center for Social Science Research at UCT. Her work focuses on preventing violence against children, and she was also supervised by Alan during her postdoctoral fellowship, which I think is when I also met you at the same time. So without further ado, I'm going to pass to Cathy, and we'll move forward.
Thanks very much, and thanks to the Centre for inviting me to do this talk. I've had quite a lot of fun putting it together. So I'm going to give you a bit of a retrospective on the work that we have been doing since about 2010. I'm going to try to draw some clear links for you between parenting and mental health issues. I'm going to talk about going to scale. I'm going to tell you about the things that have gone wrong in all of those studies. And I'm going to start with where it started. And it really did start with Alan giving me a start in my career. I don't think I'd have one without him. And we published together a number of papers on exposure to violence among children, able to show that there's a lot of it around. And that was a representative study in Cape Town when we went national with the latest study that I led with Lily Arts and Patrick Burton. We were able to show that over 90% of children in South Africa have been exposed to some kind of violence, and over 30% to some kind of sexual violence. That does include exposure abuse, seeing things that they didn't want to see, but also the more contact forms of sexual abuse. We also know that violence against children is very, very expensive to economies. In South Africa, it costs over 4% of our GDP, was the estimate that we found. And that was, we didn't even manage to incorporate all the justice system costs. So that is an undercosting of what violence against children does for us. And we know that this kind of high burden, high cost is true for many countries around the world. And we also know that families are key when it comes to children's conduct problems, which I don't need to tell this audience is a form of mental health issue. And so right back when I was doing my PhD, that was one of the things that we found. I wanted to also just to point out some other links with parent mental health that you may be a little bit less familiar with. This comes from my colleague, Lucy Kluver's work, and she's looking at key factors in parenting. They reanalyzed two very big data sets to look at what happens if your caregiver praises you for getting things right. And I've circled the mental health stuff. You can see lower depression, less suicidal ideation, less PTSD, less substance abuse, and better mental health in general. But also parenting sets the ground for to prevent those things from happening in the first place by more pro-social behavior, but less violence exposure, an older sexual debut, and better relationships with peers. So praising a child can have enormous effects on them and on our communities. And similarly, if caregivers monitor their children, in other words, they know where they are and who they're with, we again see less PTSD, and we see improved abilities to concentrate. And again, part of that is because of the protection that is offered by a parent who knows where you are. And so there's later sexual debut, better peer relationships. Caregivers are less likely to be abusive if they're monitoring. and kids don't get into violence themselves. So the question becomes, how do we support parents? And I'm really happy to say that we know very well that parenting programs can be effective in preventing violence against children. Frances Gardner, Sophia Backhouse, and other colleagues were instrumental in doing massive systematic reviews, the like of which I hope I will never be involved in, but are extremely fruitful. And if you go on the WHO website, you can download this documentation. But we know from 435 randomized controlled trials, the gold standard for program evaluation. In 65 countries, the parenting programs work. We have evidence that they prevent physical and emotional abuse and neglect. And some programs also are effective in reducing parents' depressive symptoms. Not all of them, not all of the time, but it is one of the things that we should be looking at very carefully when we do parenting programs. And then what goes into a parenting program? We have evidence now for some really important key core components and content. So teaching nonviolent discipline obviously gives parents alternatives to using corporal punishment. Nurturing care is key. We need nutrition, particularly in the early years, and parents who are responsive and attuned to their child are actually better at giving their child nutritious food. Positive interactions between parent and child, teaching parents to use praise and rewards, family rules, parental monitoring. Problem solving is a lovely generic skill to teach parents because you can't cover everything in a parenting program, and it gives them the tools to work with other things that they are confronted with. And as you may know, is a key tool in mental health programs, CBT mental health programs as well. And then helping parents regulate their emotions and reduce stress are also evidence-based core components. We also have some evidence about some of the processes. So for instance, effective programs use role play so that when parents learn about a new skill, they actually learn to do it and leave with some sense of self-efficacy about being able to implement it. And so parenting for lifelong health has been what we have been working on. I knew that parenting programs were going to be important for preventing child maltreatment, particularly of younger children, and that those children were less likely then to grow up to commit youth violence. So I was approaching it from that perspective. And again, my colleague Lucy Kluver had identified that violence goes up in the teen years and also is particularly acute in HIV-affected families. So the two of us applied for a grant from the same donor to develop a parenting program and test it in South Africa. And they wrote back to us and they said, you're both working in South Africa. Would you like to work together? And we said, that would be lovely. And we rejigged our grant proposal. We rewrote everything and they didn't give us the grant. Which is possibly the most fruitful not getting a grant that I've ever encountered. We also knew from some work that I've been doing with Chandra Gould, who is based at the Institute for Security Studies, that South African parents actually want parenting programs. They wanted group-based parenting programs where they could draw on the social support and they could learn new skills. We also knew that South African parents find the techniques and tools that are taught in parenting programs acceptable. And so I started exploring which of the several parenting programs have got a strong evidence base would be portable to South Africa. And the answer was none of the above. I ran the costs past our Department of Social Development, and they just said, there's no way that we can afford this amount for people to learn to do a parenting program. And we also very strongly believed that there needed to be an evidence base for programs that are offered in low and middle income countries. High income countries can't really afford to waste money on programs that are ineffective or harmful, and even less so can folks in low and middle income countries. So when we were contemplating this, we set out a list of values that we were always going to adhere to. So evidence of impact is one of those. We wanted programs to be scalable and to be low cost. If they depend on highly trained professionals, that's not going to be true, for instance. So we set out to train lay community members to deliver the programs. We also wanted them to be open source and freely available. So none of us earned any royalties from the use of our programs, which is not true of several of the other evidence-based programs. So you can go on WHO website or on the Parenting for Lifelong Health website. You can download the manuals for free. We do think you'll do a better job if we train you, and that unfortunately does cost money because trainers have to eat as well, but we've made them as low cost as we possibly can. We also did not go with video vignettes at this stage, but rather that we gave parents comics that could be printed out on a piece of paper, and it's much easier therefore to run a parenting program in a context where, for instance, there might not be electricity. We wanted to make sure that they were adaptive and locally relevant. So we developed the programs. Like I say, we think they'll go better if we train you, but if you want to take them, use them, adapt them, we're not putting any restrictions in your way. And there are a couple of evidence-based programs that have failed in new contexts, and we think that part of the reason for that is that the developers held very tightly to the design and said, you have to do it this way. No, we understand your context is different, but you have to do it this way. And I don't think that works very well. We also made a commitment to local leadership and collaboration, and we want our programs to be playful and empathetic. And I think this is a map where PLH programs have been used, have been scaled, have been tested. It's not always been tested in the place it's been scaled, but I don't think we would have had this kind of worldwide reach if we hadn't had those principles in place, because it's actually made it very accessible for people who are running charities or for governments to take and to use the programs. This gives you a sense of what is in the program. So I wanted to give you just a little bit of a flavor before I go on. This is from Parenting for Life for Young Children when it was developed initially developed in South Africa for Xhosa families. And we use the metaphor of building a rondel of support for you and your child to kind of stage things. So you can see that we start with the mud walls, we start at the bottom and we work up. So the first group session, parents set goals for their children. It is their own goals. The only thing we help them do is make it measurable and specific so that they know when there's been a change. And quite honestly, we often leave the goals behind as we go through because parents start to see the rewards quite early on. And then we do child-led play, descriptive commenting. Saying what you see is a really handy thing for parents to do because it shows them they're actually focused on what the child is doing. And there is the potential, although we haven't been able to measure this yet, that it could improve young children's vocabulary. Naming feelings, the first step in emotion regulation, praising and rewarding for doing things that you want to see. Giving clear, positive instructions is a skill that we try to teach. It's actually, I think, one of the more difficult ones. But instead of saying to your child, don't shout, you say, please talk quietly. And it tells them what they're supposed to be doing and not what they're not supposed to be doing, which kind of leaves a vacuum. We talk about household rules and routines so that everybody knows where they are and they feel safe. For young children, ignoring difficult behaviors like temper tantrums. Cool down. When I was training, we taught timeout as a punishment, but it's much more appropriately, I think, now being used as a time for parent and child to calm down. It finishes when they've had a chance to talk over whatever was going on that was wrong, and they've been able to catch children doing something right. Using consequences. So if you spill the milk, you get to mop it up. That's your punishment. No need for yelling and hitting and whatever else. Problem solving, I've already mentioned. And then my colleague Judy Hutchings is absolutely insistent that all of this has to happen in the sunshine of positive attention all the way through. So this is the program that we designed for 2 to 9-year-olds. we also designed a program for 10 to 17-year-olds. And I thought I'd give you the findings for this. So you can see that we have a huge range of positive effects from, in this case, a 14-session program. The young children program is 12 sessions long. So more involved parenting, more parental supervision, less abuse, less parent stress, less parent depression. Parents have more social support. We build that in specifically into these programs, so each parent gets a buddy that they can touch bases with through the week before the next session if they need it. Parents use less substances, teens use less substances. There was better planning to protect teenagers in communities. There was less poverty in the sense that two of the sessions that we introduced in this program are family budgeting. So both Lucy and I were incredibly skeptical about the power of that. But Lucy had a couple of doctoral students who absolutely insisted. So we said, okay, that's fine, go ahead. And it's turned out to be the two sessions that families enjoy the most. And it has really helped them to manage their money better and to talk to their children about money matters. And it makes it easier to stick to a budget through the month. So they're more likely to have food all the way through to the end of the month. Then we had no difference, unfortunately, on consistent discipline, positive parenting, teen problem behavior. The p-value was sort of borderline 0.06, teen depression or teen social support. But we also found that we didn't have any negative effects. And that was a really lovely set of findings. We pretty immediately moved from South Africa to working in the Philippines. We had promising results in South Africa. They weren't stellar. Both the studies that Jamie Luckman and I led, the control group had the extreme bad manners to improve as well, which didn't happen in the Philippines. And I don't know what the difference is, except that maybe we strengthened our measurement in the Philippines and used more direct observation. But we know that the components, the content is culturally acceptable in the Philippines and in Thailand. And in PLH for teens, we know from South Sudan, for instance, that the program transfers well even to intensely conflict-affected situations. And we know that the program is feasible in the Philippines, and so is studying it. We've been exploring in the last few years to take our programs to scale. So one of them is integrating parenting programs into existing delivery mechanisms. And we now know that Parenting for Lifelong Health for Young Children is effective when it's integrated into the conditional cash transfer program in the Philippines. So the Philippines does not, like, we have our child support grant is means tested, and that's the only thing. You are poor enough, you get it on application. The Philippines have a conditional cash transfer program, and depending on what you do, you get more money. So enrolling your child in school, vaccinating your very young children, and attending family development seminars. And Parenting for Lifelong Health for Young Children has now been integrated into that system with quite a few modifications, like it gets delivered only every 2 weeks, and then the facilitators send out sort of booster texts during the week. But that way, we've been able to reach 4 million children in the Philippines. In Thailand, the final outcomes paper isn't ready yet, but the village health volunteers, who are like our community health workers, love running the program, and we can reach a lot of people that way. In Montenegro, it's been integrated into the early child development centers and the kindergarten, the first few years of school. And that seems to be going pretty well. And we've also been able to integrate it into service delivery systems, in this instance, run by NGOs in Moldova, North Macedonia, and Romania. I think in Romania, it's actually also being delivered through the city systems. It's effective, and we think that brackets in the short term only was because this was one of the huge impacts of COVID, was that we were about to test our newly designed program, and we had to take it online. And I don't think that that was the most effective delivery mechanism, but it did have some effects, at least in the short term. And then PLH for teens was used in its in-person lengthy format in at least 8 different countries in Africa. We were able to work with our colleagues in those countries to collect pre-post data, and we were able to show a lot of reductions in violence against children and improvements in mental health and so on, even in that sort of huge dispersal mechanism. What happened was that this is largely USAID funded, so folks like Catholic Relief Services and Plan International and so on, who were already receiving USAID funding, could apply for more funding to run a parenting program, and specifically PLH for teens was one of the ones that USAID mandated. And we would see 20,000 families in the country getting the program, which is absolutely amazing. We have us a lot of headaches about data collection, but it was really, truly amazing to see that. So one strand is integrating the parenting program into existing systems. Chandra Gould and I then decided what we would do is we would tackle a whole community, and this is now skipped around. Hold on. For some reason, it's showing slides that. Next slide. There we go. This took place in the community of Toast-Runton. In case you're worried about me breaking confidentiality, Toast-Runton, the community voted to have their name included in this. They gave us an enormous amount of time and effort over, in fact, 5 waves of surveys. And our goal was to try to reduce corporal punishment community-wide, as well as to improve mental health community-wide. We had done some earlier studies that showed that corporal punishment was widespread in the community, and that about 20% of the children in the community would have benefited from a mental health intervention, either for internalizing or for externalizing reasons. And we used the child behavior checklist here, which is a pretty robust instrument. So what we said we would do is we've drawn all 4 Parenting for Lifelong Health programs. Now, I've only really been directly involved in the ones for young children and for teens, but we also have dialogic book sharing in the stable run by the Mukulu Trust, and the parent infant home visiting program that the Parent Centre was currently using. One of the reasons for choosing Toast-Runton is that it's a bounded community and people tend to stay there for a long time. The population's pretty stable. So we could do longitudinal surveys and track what was going on. And there was a strong NGO, the 7 Passes Initiative, who ran these programs. And then alongside that, we had a social activation program, which was facilitated by Warren Parker. So he worked with community representatives to develop a brand for positive parenting that people could aspire to. And we had a group of folks in the community members, who then ran family-friendly events and disseminated parenting information through their networks. Our evaluation was we did a baseline survey, and then 7 Passes then started rolling out the programs, and we did another survey 18 months later, and then again 18 months later. And this is the results in pictorial form. You can see that parenting stress plummeted over the period that we were running the program, and that was statistically significant. Positive parenting didn't change very much, and that's every time I've done a study, all the parents say they are using some positive techniques, and that's, most parents want the best for their kids. So they might use corporal punishment, but they usually completely understand praising and rewarding and so on. And we were able to show that children's mental health also improved. Now, what we also measured all the way through this was intimate partner violence, parent mental health problems, and alcohol use by parents. And we found that those 3 things, despite the community-wide improvements, those 3 things still affected children's mental health, and the parents who were experiencing them were less likely to use positive means and more likely to use corporal punishment. Toastranton is the township, the former township that was outside Hookville, which is outside Wilderness. It's not the most rural of townships, but one of the things, for instance, that systemically was difficult in the community was that the local clinic did not do any mental health treatment, not even dispensing antidepressants. And we had some parents who were really seriously mentally ill. And so that kind of thing, the only thing to do, if it wasn't organized by our social activation group on a Friday, if you wanted to socialize, would be in an environment where there was lots of alcohol. And of course, those things fuel intimate partner violence. So one of the takeaways from this is if you're going to try a parenting program, you have to think ahead about these other things that affect families and try to mitigate them, find some way of referring people onto those services or integrating them into your program. And then the third strand. Along came COVID, and none of us could leave our houses, let alone run a parenting program. And Lucy Kluwer got out of bed one morning, looked at her 2 young children and thought, how am I going to cope if schools close? And so in a massive, rapid effort, our parenting programs were distilled into social media tiles and a website. There's also a song if you go on the website, which you're welcome to play with your children or your grandchildren when you get irritable. It's a song about de-stressing. And these COVID-19 parenting tips reached 198 countries. We had people, you know, I had a postdoc from Nigeria, so we translated it into the local languages, and we had, you know, Oxford University has a lot of international students, so they did translation. UNICEF country officers stepped up and did translation. It was really a massive global effort. The tips were used in 33 government programs, and from website hits, we estimate about 210,000 families around the world received these. And what also started happening was my postdoc, for instance, sent these parenting tips to his friends and relations around the world, and they went, this is amazing, can we have more? So we started to innovate. We started with what's called Parent App, which has just been very successfully tested in Tanzania, reaching thousands of families in the study. You can see what Parent App includes. It is an app that can be used on a very basic smartphone, so it doesn't necessarily need the latest technology. You don't, once you've downloaded it, you don't even need to run it. You don't need data to run it. And we've had some very, very positive results, including from the reductions in sexual violence, which I never thought we'd see, and all for a cost of $6 per family. It was run in the study. We discovered it's a little bit better if you have an in-person onboarding session where you can orient parents and show them how to use the app. That tends to make engagement much better. But one of the takeaways that we've had from this work is that dads are much more likely to engage with a parenting program that's digital than they are with an in-person parenting program. In fact, in Toastranton, we set up a dads group. And the dads said to the facilitators, so amazing, we're really loving this. Can our partners come? And we thought about it and we said, yes, big mistake. The partners came, the men left. Yes. It's one of the things we're really going to have to tackle more seriously, but that is one of the happy findings from that. So here are the findings. Improved mental health for caregivers and children, less financial stress, back to those family budgeting sessions. They really seem to be very powerful. More positive parenting, improved supervision of children. That's no doubt why we found our sexual violence risk factors dropped, and caregiver child communication improved. Attitudes to all of this, to physical punishment and so on, also improved. And then a set of sexual violence risk indicators reduced, child abuse reduced, and intimate partner violence also reduced. And that, I think, is really key because It's much easier to parent if you and your partner are in agreement. And it is, some people would cast intimate partner violence, witnessing intimate partner violence as a form of child abuse, because as you all know, it's really traumatic for children to see that. But we also turned our programs into a chatbot called Parent Text. We initially distilled the parenting program, or the whole parenting program, into a many-week chatbot, and discovered, however, that parents do engage with it, but they tend to drop off at 5 days. So we then did another brainstorming and were able to distill our programs down to 5 days, 1 lesson a day, of the more positive things. And this has been tested in South Africa in a randomized controlled trial. You can see the chatbot on the right. This does include some videos. We are seeing that most parents now can access the videos, although it's not essential to them. It is helpful to have somebody explain it to you. This is our AI video lady. She's pretty good in a lot of languages around the world, but there's no AI for isiXhosa. So that we had to record in a studio for some work that we are currently doing. And here are the results. You can see that not all of the effects endured to the 7-month follow-up, but it's still pretty astounding that a very light touch parenting intervention that literally, when we recruited people on Facebook, is able to have this kind of effect. And that was analyses of over 23,000 parents who submitted complete data. In other words, they took all the surveys. And so now we're going to draw some strands together. The SWIFT study, which stands for Strengthening Wellness Through Integrating Family Treatment, is where we are putting up posters. You can see the 2 posters. We refine those in our pilot. Posters will go up in the clinics for about a month, and we'll see how we recruit people. And then in the next phase of the study, we're going to ask health practitioners in the clinic to start encouraging people who come to the clinic to join the parenting program. Initially, we were restricting that to only nurses, but the pharmacists asked to be included, the security guard in the clinic asked to be included, and so we just said any staff member in the clinic can now encourage people to join in. We have ethics approval. We're just waiting approval from City Health and from Provincial Health, but it may very well be that if you go into a clinic in Delft or a clinic in Ceres in about a month's time, that you'll see our posters up. And that's, yeah, so that's integrating into a system and using the 5-day chatbot experience. And then we're also doing an RCT of a sexual violence prevention 5-day module. But there are some challenges. So what I didn't tell you with our lovely, spectacular results from Toast-Runton is that at the time that we did the 3rd survey, there were roadworks happening in the community. So the road from George all the way through to the farms where many of the people worked was having massive renovations, and many parents got employment in those roadworks, you know, waving the flag or doing the waving manual labor or whatever. And so they were better off financially. And this may have been the causal factor for the parent stress dropping. We can't isolate it to whether it was our program or whether, in fact, it was having more money. And I think that that's something we also have to take very, very seriously, along with our findings that parents love the family budgeting. So we went back at one point, and when we looked at the cluster randomized trial in South Africa, we looked at the original data, and we were able to show that 4 things mediated improvement in the teen trial. Improved parenting practices, improved caregiver mental health. That's really helpful when you're trying to change parents' behavior as well as their children's behavior. Avoiding drugs and alcohol also really helps, and improved family economic welfare, which came from those family budgeting sessions in this instance. And so I think it's not only about making sure that families have enough to eat all the time and can, they have enough money to go forward. There's still a place for parenting programs, but I think we also have to do the reverse, looking at our parenting programs and making sure that family budgeting is integrated into it. And then we've also learned something about digital recruitment. So this is from our SWIFT pilot. On Friday the 12th, we all finished, Thursday the 12th, we finished our work, we went home, and then my colleagues phoned me first thing. It happened to be Friday the 13th. We'd had over 18,000 parents try to join the chatbot that night. Now, this had a number of really bad effects. One is it used up all our money for incentives. It actually crashed the payment system, which can't handle more than 2 requests in a second. We also had 1,801 reports of child sexual abuse, which was extremely alarming and had me on the phone to the ethics committee first thing. We figured out what had happened was that we had, in retrospect, very stupidly given incentives for recruiting the baseline questionnaires. We'd given folks 25 Rand in airtime vouchers. And we thought that that would help them to go through the rest of the program. But it became, what people had done is they'd gone onto parent groups, admittedly, mostly, but groups that had 2 million followers and said, text this number, say you live in the Western Cape and your child is between these ages and you automatically get 25 Rand airtime. So we have, after long discussions back and forth with the ethics committee, we've taken out all incentives except for the third. We've designed a study that has a baseline, a 1-month survey, a 3-month survey. You get 5 Rand in airtime for completing the 3-month survey. And by that stage, the chatbot will not be accepting new people. So we don't think we're going to see this again. But it really was Friday the 13th. So if you're doing study in the digital sphere, be warned, think through your incentives. So where are we going and what's next? One of the things that we really want to do is to build a pyramid of parenting support. Obviously, the digital means gives us the opportunity for every parent everywhere to get some kind of parenting support. But there will be families who need more than a 5-day digital program, and we are building more modules, but they'll need more than that. They might need more than an app. And so we think that there will be room in a pyramid system where the families who are still struggling to get an in-person parenting program. And there will always be those families who need one-on-one treatment in a tertiary treatment center from a psychiatrist and a psychologist and whatever else is needed. So that is an ambition that we have. And then I think other areas for research and practice, I've sort of talked about some of these, but including fathers is really crucial. They have a really important role in children's lives, as you know, and we are going to be looking at our data. This is what Lauren van Niekerk is leading, looking at our data to look at specifically at the men who engage in our parenting programs. They do seem more likely to engage in digital programs than they were in the in-person programs. But Natalie Davidson and I found that we had no problem engaging men, at least in rural Zimbabwe, if we specifically and pointedly recruited both members of the couple to the program to start with. We also were able to build in some gender transformative content and some content that was about couples conflict, and we were able to show a reduction in intimate partner violence in that version. It was an in-person version of the teen program, but we're doing this in all of our programs now, and we need to explore that more deeply. Family budgeting, I've mentioned. My colleague Cindy Brains is very good at saying we have to embrace the power of social media. Now we've had this horrible experience where the payment system crashed. And so what we've done in the SWIFT study is if you finish the program, you get sent a social media tile that you can then post on social media. And we've found a way to track those parents who join following adverts on social media versus those who join from the clinic. And we're going to be able to explore those two and see what happens when parents network with each other. We really need to do more work on implementation, the best way to implement these programs. We've got some hints and tips, as you've seen, but I think we also need to explore and understand the policy arena much better. And Carly Katzik will be doing her PhD in the Centre for Public Mental Health around exactly that topic. Helping parents keep their children safe online is a new challenge, and Shalini Singer and colleagues are working on a program that we're going to call Safe Online. We need to think about mental health and substance abuse treatment. And then I think there's going to be a new frontier with artificial intelligence, and it may well be that we reach the point where if you start yelling at your child, your phone beeps and says, here's a better way to handle things. So we'll see. That is obviously a very complex frontier. We're learning AI as it is developing, and it is fraught with many, many difficulties, as anybody who teaches undergraduate students will know. So I think those are the sort of frontiers of science on parenting programs. If you are interested in more, you can follow us. The Global Parenting Initiative is our research arm, but we also, because of the demand, have actually found ourselves having to set up an NGO called Parenting for Lifelong Health. They have a website. Clowns Without Borders South Africa also deserve a shout out, who have been our implementing partners in this country and across Africa from the very beginning. And so that is the story of how looking at exposure to violence with Alan Flisher has actually spawned a whole set of research studies, and the story isn't ended yet. Thanks very much.
Kathy, what a wonderful, provocative presentation. I'm still a bit startled about the cell phone that beeps when you're yelling at your children, but I think it might be something we need to get used to. We have some time for questions. There's a question at back 1 and 2 and 3. Would you like to take 3 at a time?
Sure.
Okay.
If my memory doesn't hold them all, we'll just come back.
So 1 and 2 and 3.
Thank you. Thank you so much. I think that was really very well. I've seen that over the different humans. So I'm currently, and for a long time, I'm going to be clinical psychologist for the female acute unit, and I would try to incorporate a lot of my brain skills, especially post-psychosis, because I think that's something they can hear about bringing the body. And now that they are here, whether mothers or caregivers, that there's an opportunity to kind of, plant the seeds for there to be a reattachment of the body. And I was wondering, I'm going to throw 2 questions just about, do you think that this is adaptable to the food setting? And the second question is, why not, for example, the Marshall interaction method, and why this?
Okay, sorry, waiting for all 2.
Okay. I think it somewhat taps into that, and I mean, of course, you said that the best way to get these programs scaled is to integrate into existing systems, and the work goes through clinics and now for digitally online as well. And I'm sure you have explored the space. Maybe you could tell us why it isn't perhaps part of the school system, like integrated into that. And then, because of what us are doing school-based work, we kind of laid the foundation for a lot of what we want to do. There's a lot of overlap. There's a lot of space. And then the other thing is, you mentioned 4 sort of repeatedly the budgeting thing, which seems to be crucial and radical, and just families. I know most adults in my friendship circle really benefit from budgeting sessions, so I really do feel like that is key. And then there's also parenting practice, parenting mental health, avoidance of drugs and alcohol. But if parents only ever attend 1 session, what would that be?
Okay, I think I'm going to have to take, that was 4 questions. I certainly think that this could be integrated into the work that you're doing in the ward. It will need some creative thinking about the children aren't there with their parents. And so you may have to do role plays during visiting hours, that kind of thing. We have had success with curated WhatsApp groups where people do some in-person sessions and then get boosters outside. So if you have a patient from far away, maybe considering WhatsApp boosters is a way to go. But of course, if people are transitioning into outpatient care, it may very well be feasible to provide them with support in that context. I mean, I do have an ambition that every single clinic in the country will have a psychologist, a registered counsellor, a lay counsellor who is trained to deliver these programs and offers them regularly in the community. I think that would be wonderful. And if it could be integrated into post-hospitalization care, that's great. You asked about why this rather than parent-child interaction therapy, or? Okay, either I'm not hearing you, sorry, getting old, or I'm not catching the name of it.
Marsh.
The MIM, Marsh interaction method, is the interaction based on the attachment style that focuses on the different sections of nurturance, engagement, challenge, and structure.
Okay. The reason why not is we didn't think about it. There's no substantive reason for, I'm not, Parenting for Lifelong Health suite of programs are by no means the only parenting programs in the universe. And if you looking at the content, you will see that none of them is rocket science. I do think it's that they're free. They have some driven researchers who like to experiment with them. But I would love to talk to you about adapting it. I think there's some really interesting systems things that we could talk about. So that would be great. Bronwyn, the question about schools, I have so little faith in the education system in South Africa that I am the Grinch in South Africa, but I think probably more could be done. My colleague Judy Hutchings, who has done amazing work with developing the Incredible Years program and getting it rolled out across Wales, and has been doing similar things with other programs, says she loves to work in schools, and I am being silly, and it's entirely possible that that is true. And I think there are lots of ways in which we could promote, especially the digital programs, which don't take teacher time. I think that might be a way to go. And again, if there is a school counsellor, they could be doing some kind of hybrid thing with parents. There are all kinds of possibilities that are available there. And I have forgotten the second question.
One session, single session.
Oh, the single session. Child-led play can be transformative for parents and children. It's the very first session we do, and it's intended in this sort of behavioral approach to establish the parent as a reinforcer, so that, because very often if the parent-child relationship is quite fractured, because if you have a child who's difficult, there'll be a lot of moaning and complaining, and that's what the child experiences. And setting aside, and we've discovered 5 minutes a day is enough to turn that around. And lots of parents feel like they don't have time to spend with their children. 5 minutes can actually be really quite transformative. I don't think clinically that it's enough to turn a whole family system around and to embed the behaviors, but I think it's really important. And I think embedding that with maybe some information on praising the behavior you want to see could be really helpful. I forgot something off my presentation, and I should actually have brought it in, but I have a very creative PhD student in Zimbabwe who has managed to collapse some key content from Mikulu, the dialogical book sharing, and from Parenting for Lifelong Health into 2 sessions that she is hoping to roll out. In Zimbabwe, there are 2 years pre-grade 1 that are now mandatory. And she's hoping that those will be rolled out through the education system in Zimbabwe as a means. So when parents are keen and eager when their first child starts school, you catch them then because they'll come. And I'm waiting for the results from the RCT that she's just done. It should be any minute now. But I think there are lots of creative things that can be done with these programs. So you don't have to hold it to a rigid 12 sessions or 14 sessions, which is a huge commitment for a parent to make.
There was a third question, okay, and one, and then two, right?
Thanks a lot for your presentation. It was really fascinating. There's very much happening. It's really fascinating. I was curious about specifically the sexual violence strategy and how your programs you sort of build a reduction in sexual violence. I'm not sure if this is specifically sexual violence against children or women or perhaps both, but I'm wondering first why you think that fact happened, and secondly, if you think of this as actually something that would be long lasting, and not just straight to a survey. You already mentioned.
Okay, let's take the other one as well. I'll answer.
So I'm part of the Division of Child and Basic Psychiatry at Children's Hospital, and so I was listening to your presentation. I was thinking about how clinicians could benefit from it, but specifically the nursing staff in our team that therapeutic work. So that's just comment. And then question is, were there any exclusion criteria for the parents who were included in the studies? The reason I'm asking is I was thinking about parents and children with intellectual disability or developmental disabilities, and whether the same principles would be used with populations.
Okay, I'm going to start at the end. I think the same principles certainly could be used with that population. There's praise, rewards, consequences. I'm not so sure about intellectual disability and consequences, but praise and rewards certainly going to work with pretty much anybody. I do have a colleague in China, Zui Fang, who's working on disability versions of the program. I think that there is lots of room, so Ronald and I were talking about ADHD earlier. I think there is room for bringing parents with a child with one disability together so that they can have some psychoeducation about that disability and understand why these principles might work and so on. And I think, ID is another example. Parents of almost any disability are probably going to benefit from this. To answer your question about nurses and other staff, one of the things that I didn't say was that in the ideal situation, the people who are facilitating the program get some coaching every week from somebody who's trained and experienced in the program. And we would love to have more professionals getting trained so that if it gets dispersed more widely, we've got a cadre of coaches who could do this. And it really helps if there's somebody who's got a professional background, OT, social work, psychiatry, psychology, because quite often questions of child development come up, for instance, and it's really helpful also to be able to give the facilitators a broad picture of what might be happening in an interaction. So that would be great, and I'm sure Clowns Without Borders would be delighted to come and train as many people as you can pull together. And I'm going to take questions one by one because clearly my short-term memory isn't going so well, so sorry. Yeah, your question, sorry. Yeah.
Sure.
Yes, please. Sexual violence reduction, okay.
Reductions for sexual violence against children or women or both, and why is reduction happening, and if it's well enough.
2 seats away from you is Lauren Barrick. Lauren, do you want to talk about the app? Are you able to talk about the app and reductions in sexual violence, or shall I just go for it? Okay. Okay, thank you. Some of it is reductions in risk behaviors. So it's being somewhere when your parents don't know where you are, being with friends who are drunk, taking a lift in a stranger's car, that kind of thing. And a lot of the program has the parent and the teen sit down together, draw a map of their community, mark off the unsafe places, and then talk about ways to avoid them and explain, and it also explains why your parent needs to know where you are. There's better communication between parent and child, so children are more likely to say to their parent if something is wrong. And there's also some education for the parent on what to do if your child is raped or something like that. So there's a set of education about how to react, which is not you are a bad child, obviously, but how to be accepting, and then think about the things that need to happen, going to the nearest clinic, you know, getting HIV prophylaxis, getting whatever rape kits done for the police and so on. So that there's a set of conversations about the risks that teens might get into, and a safety plan if they do find themselves in an unsafe place. You know, they can get hold of their parent and come and say, this party feels terribly unsafe, come and get me, that kind of thing. And I think just surfacing those issues and making it possible for people to talk about them is really key. Or do you want to add anything to that? I've done well. Excellent. I'm not involved in that particular study, other than, you know, it's happening in the broader groups, so I can just celebrate from afar.
Seems we've come to the end of our time together. So I want to say thank you very much indeed to Kathy, to Professor Ward, for a wonderful presentation, a wonderful talk at this Alan Flisher Memorial Lecture. And thank you.
Thank you.